Yes, good morning once again, and you're still watching Church of Uganda Family TV, and specifically now it is issues at hand in Good Morning Family. A lot has been going on, like since we started in the morning, but now we are going to dive into issues at hand. Basically, issues regarding Ebola outbreak in Uganda. Now, it's on 20th September, that is 2022, the Ministry of Health confirmed the first case of Ebola outbreak in places around Mubende, and on 11th January 2022, there was a declaration that yes, we now have Ebola. But since then, there has been a good response, bad responses, but depending on what the circumstances were and how people were affected or people responded, things like that. And now that's what we are going to discuss today. But a brief background on the outbreak. On 20th September 2022, the Ministry of Health in Uganda, together with World Health Organization, AFRO, confirmed an outbreak of SVD in Mubende district, Uganda, after one case. Now, the first case was a 24-year-old man, a resident of Ngabano village in Madudu. Yes, Madudu sub-county in Mubende district. That was the case, and it's part of the virus and all that. You saw a mini lockdown of the places around Mubende region. But yes, we had to maneuver through, and here we are. I have a very exciting panel today, members who are going to help us understand more of this issue, basically. And I truly welcome the gentleman and the lady. You're most welcome to Good Morning Family and Issues at Hand.
Thank you so much.
Yes, and now I have Resty Kyomukama, and she's going to briefly introduce herself to us.
Thank you so much. Good morning, our dear viewers and listeners. My name is Resty Kyomukama and I work with the Alliance of Women Advocating for Change, which we shorten for AWAC. And when I'm speaking, I might be saying AWAC, okay, but that's for Alliance of Women Advocating for Change. Okay. We sit in Mengo, Balintuma Road there, but we work in about 57 districts, okay, of course, including those that were hit by Ebola. And AWAC is an organization that was set up by women from marginalized communities, and they looked at issues that affect them, and those including female sex workers, women living with HIV, and they were like, we want to do some change in our communities. And so in 2015, AWAC began its work amid its different challenges, but until now we are working in 57 districts and working in areas of HIV prevention and response, also talking about care, speaking about public health emergencies like Ebola, COVID and all that. And we also work on different sexual and reproductive health rights issues. And we give services through different channels, looking at our DICs. DICs is drop-in centers where people come and just get support for their health needs. Okay. Yes, maybe I'll stop for now. And
yeah, that's interesting. And Mr. Raymond there, please do introduce yourself to our viewer there.
Good morning, our viewers. My name is Raymond Kwesiga. I work with National Forum for People Living with HIV AIDS Networks Uganda. Okay. This is an umbrella organization for people living with HIV across the country. And we are in every district across the country.
That's interesting.
Yes. So in every district in Uganda, we have a district forum of people living with HIV. And NAFOPHANU made her 20th birthday, and we are very soon, having celebrations for the 20 years.
Oh, wow.
Yeah, and the districts that were affected, we had a very vibrant team of people living with HIV in their forums that supported in service access, supported in delivering ARVs to people who needed them, and basically because it's the work of the forum. So the secretariat is basically having coordination of it's having the coordination role basically for people living with HIV.
Okay, that's interesting. So I'm hoping to be invited at the celebration.
Absolutely.
Okay.
Absolutely.
So Mrs. Resty, I want us now to dive into the discussion, and basically we are speaking about how communities responded to Ebola. And now I want you to take us through what really happened specifically during the Ebola period before we reach to what the response was. Yes.
Thank you so much for that question. For those that are unaware, probably, there were cases of Ebola in about 3 districts, but also some tracked cases in some other districts. And we decided to work in all these 5 districts. And we've worked in Mubende, Kasanda, Masaka, Kampala, and Wakiso. And you remember what it was for COVID, but that also replicated in Ebola period. And when we speak about an emergency, a public health emergency, people get on tension. There were lockdowns where people's incomes were cut, whatever they were doing was reduced, you know. And as AWAC, working with women who are affected in multiple ways. When I say in multiple ways, they are affected because of their social status, because of their economic status, because of who they are, what they live, communities, how communities perceive them, and all that. So working with such a marginalized population, they are even affected more. And these compounding vulnerabilities even make them interface with the realities of the lockdown and those the environment that public emergency creates in a different way. We all know how the lockdowns affected us, but it wasn't the same for everyone. You know, for women, I'll give you an example. For a woman, being a woman,
yes,
first of all, in society sees me as unworthy to be out there. Now, being a woman, then a woman doing or working as a sex worker, society is like, you're a sinner, and why are you even, you know? And then on top of that, their social status and economic status, they don't have money. Like they live, you know, hand to mouth. So all that makes them extra vulnerable. And when there is a lockdown, it means a woman who was living hand to mouth, their income has been cut off.
Yes.
You know, it means they're supposed to face that in a way that if they have a family to feed, which most of them are, they will have to find means to take care of their children. But police will be out there saying, hey, 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 we shouldn't see you out here because it's a lockdown and you could be intensifying this problem we have at hand. But we see that all that affected them. And as responses come in during the lockdown, those responses stop immediately. The Ebola is announced to be out of the country. But we often forget that what the public emergency has done to them is even worse, because they are left without income. Some of them, you know, they could have had a capital of 20,000, you know, and now during lockdown they've eaten it all, and they have nothing else. So meaning they will not have even startup capital. They will not have basically a way to live. And we need to speak about the effects. What is the effect of the disease of Ebola? You know, like what are those things that were left behind because of Ebola.
Yeah,
And
so-
now that we are past Ebola.
Yeah, that's interesting. So
yes.
that's what we are going to dive on when I get you after Mr. Raymond. Mr. Raymond, how does Ebola affect the people you are advocating for during that period?
Okay, thank you very much, our moderator. Ebola affected individuals in different spheres. That is psychological, affecting the mental health of individuals, service access. You realize that when a lockdown is there are no movements. And our individuals or our people need to access ARVs, not only ARVs, other medications, but you can't reach to the health facility. This affects people psychologically. Now what next? I have to take my ARVs. You are being told you have to swallow your medicine every day and on time.
So
and now,
as per that time, there was no provision for like people with ARV, with living with HIV, like, because I remember during COVID-19 lockdown, they used to at least move these services closer to them. In Ebola, it wasn't.
There was that's where I'm going to.
Okay.
Yeah, because when there is an outbreak and a lockdown is is prompted.
Yes.
What happens is now the government begins planning. Now, how do we reach the people?
Yeah, exactly.
Now, at this particular moment, we have to now look at the implementing partners within the district, and they have to work again with people who are within the communities, because they know the communities better. And now, by the time the services again reach these individuals, remember, some had appointments to reach to go to health facilities for refills, but which didn't happen. Now they are told, hold on. Then a plan has to come on how the ARVs can be delivered. But again, through our community champions, through our PLHIV coordination offices, the implementing partners within those districts work with these individuals who know these communities, because these are expert clients who are at health facilities and they know individuals in these communities. So with that support, they maneuver to reach the other people who need the ARVs. Number two, about mental health. There is a lot of that distress that comes with lockdown. Yeah, you are stopped from moving. Literally, you've stalled. You're not moving anywhere. Whether it is fending for your family, like what my colleague had said, probably you have to move from Mubende town or from a village in Mubende to come to Mubende town to get money for food, but of which you cannot reach Mubende town because you've been told not to leave where you are. And this affects people psychologically. And many people needed that psychological support. But remember, these are things, all amenities that come again later after, an epidemic has, hit, or a pandemic has hit, like you saw in COVID-19. And I think it is also very important that, yes, I know we shall come to that, having that sort of preparedness mode. Yes. So many of these pandemics, hit communities, and we are like, even the government is like, now what next? So if government or health facilities or even implementing partners are like, now what is next? Okay, we need to serve people. Okay, we need to reach these communities. These are further communities, and those are the dynamics. And stigma and discrimination.
Right.
So you realize that for those families that had Ebola victims, it was terrible. Remember, now this is an individual you're not supposed to touch or reach. Probably needs something to eat, not even probably, needs something to eat.
Yes.
Needs water, but you cannot, because of that fear. Okay, so there's increased stigma and discrimination. Now it is on that individual. Then the family is being stigmatized by the community. That home has an Ebola patient, how we don't associate with them. So you see that the patient is having a double stigma. The family not reaching to you, and again the community not reaching the family, and now the community, you know, further marginalizes the individuals. Now looking at people living with HIV, it is even worse. Now, if a person needs something to eat and they cannot access it, they need to swallow their medication, it becomes a double tragedy.
Exactly.
Yes.
Interesting. So this is people living with HIV having such complicated challenge. Miss Resty, how do women, how does Ebola during this period, what are some of the effects of the Ebola to the women you advocate for?
Yeah. Thank you very much. So speaking about the effects of Ebola and also touching base on those key effects, I mentioned earlier the economic aspect is very, very vital because it tells a lot on, not like you asked earlier, if everyone got access to medicines, but some didn't. And the only option they would have to support them is if they had some money, to find a way to go, because they were not allowing borders. But if you had money to go in a cab, you would go. So you see, but money limits one in that manner that they wouldn't have even access for that. But also speaking about the mental challenges my colleague has mentioned earlier. In most cases, when something happens, because mental health in Uganda hasn't been so spoken as something vital, and you see that we still have a huge gap there, that when something happens, these physical or visible challenges would be given attention, but that mental well-being, and we have that software in us, I will call it a software, that if it's challenged, you break down. And when you break down your systems and all that you do, break down. But how do we come back to being functional beings? How do we support one another to even ensure that we actually thrive even in such cases? And the other effects on that break of togetherness. We were in Mubende, and a family that had a woman who had Ebola was shunned. Everyone said, no, don't go there. Whenever she went to the shop, they all ran away. Yes, they ran away. And they told members of their families, don't go to that family, because you might bring us Ebola, you know, and you know that stigma. And it was so heavy that even when the person is well, they will always shun that person, because it's in their mental thinking that this person still carries the disease. And we had to do a lot of sensitization in communities to ensure that there is that call back for those that were affected by Ebola, so that they can actually be supported. We've also been to communities where they've told us we actually haven't seen any health worker coming to support us, you know, and so they didn't have the medication as it's anticipated. Of course, some did get, but those are some of the things that happened. But I want to highlight that when we were working, we have something unique that usually communities are not seen as something vital. You know, yes, such public emergencies, we see the health workers, you see, you know, and everyone puts their attention into thinking that only those specialized people could support. But this time round, it's really communities. That, for instance, when we speak about communities living with HIV, they're at the grassroots. We've seen female sex workers that are displayed in their communities now becoming leaders, you know, and we've actually come up to create the community actors for HIV+, which is a community of actors that are actually working as peers and coming about and saying, we have to do for our community, we have to serve, to see that our community is better, to dismantle the discrimination and the stigma, to see that our other fellows can have enhanced economic well-being, you know, and all those things. So we've worked really on grassroots and seeing that these communities, the same communities that are supporting themselves, you know, and unlike usually where we see that it's external support coming, you know, everyone thinking that you are not worthy, you know, being a person with HIV, you're not doing this, you know, being a person doing sex work, how can you come in the community? But we've seen them supporting and ensuring that they support one another to see that their fellows live in an improved life.
Yes. Actually, if I can,
yes, I'm actually coming to you.
I just wanted to add a little on what my colleague has mentioned. I have the passion for the community, and community engagement aspect is something that we need to embrace, because communities, you know, different communities have their different dynamics.
Yes, sure.
And as you know that if a health work is transferred from this, let's say from Buganda region to another region, there tends to be a little of adaptation challenge. Yeah, sure, he is a health worker, but again, communities have those different dynamics. I went to a certain community where you reach a health facility when 10 o'clock health workers are not there, even the patients are not there, because they are first going to the gardens. They first go to the gardens, then later at around 10, 11, you see that the health workers come, and now when you reach that community, you begin saying, but how do these people work? Now there is no health work here to attend to patients, but where are the patients as well? Because they know that is the norm. So community engagement is very, very, very critical. And actually in pandemic preparedness, if communities are engaged, communities are ready and you know, and very resilient, because you know how our health systems, not everything that is required or needed is within the health facility. And now look at that protective gear for the health workers that is needed if they are to serve Ebola patients. It becomes a little tricky. And now you are engaging the community. These are the members also who are not having the protective gear, but they are going to take services to their fellows. So you get how difficult it is, because even the health workers are few and they can't reach everybody down there in the community. So community engagement aspect, as mentioned by my colleague, is very, very critical.
And actually,
just a minute.
Okay.
If it's okay, I would add to this. There is something we've learned. We learned this through UNAIDS, and we learned from the experiences of AIDS. You know, they say when you learn from your experiences, when you learn from experiences of others, you're smart. But when you learn from, no, it's like when you learn from your experiences, you're smart. When you learn from others, you're smarter, because before it reaches you. But back then, there was it's in the 80s when it hit so bad, and everyone was like, no, AIDS in the 80s. Yes. Back then, when it was something new to everyone, you know, and most people didn't know that it's actually a disease. They thought it's a voodoo. Yes, and everyone thinking, Bandoze, you know, they've bewitched me and all that. So us learning that actually that happened in Rakai, those ends, where people ran into voodoo. And knowing that this is also a community out there that people use, you know, to you know, as I will say African setting, but some, I will add that, when there is something like that, they don't understand, they don't have explanation to, they will always go to that. They seek, and of course we know that right now some will also seek that higher power of God. But we understood that these are communities that are untapped into, because communities in villages use them to seek support. And how do we bring such communities aboard to see that they actually do not go into that, so that they understand this is not a voodoo thing. You need medical attention, actually, you know. So we brought aboard Uganda Nedagano Buangwa to see that they sensitize also among that population, you know, telling them what the disease is, that it's a medical issue, and also to, you know, when they go and spit Ebola goes through that. How do they go beyond that? So we worked really in a consortium that's very unique. We worked with NAFOPHANU, Uganda Nedagano Buangwa. Of course, we were supported by UNAIDS and World Health Organization to see that this moves well. But these communities are being that uniqueness and bringing aboard all those different, I say communities because those are sub groups, but they are communities on their own, that we come together and say that how do we push out this and the effects it yields, so that we use the communities to support one another.
That is interesting. I think now that exact point will drive me to what was the response in particularly for these communities. How did the communities respond? And I'm going to start with you, Mr. Raymond. Yes.
Okay. You know, in the beginning, everything comes like a worrisome, deadly. Yes, Ebola. I'm not saying that Ebola is not deadly, but it is something that can't you can't get rid of. Once it gets you, you are gone. Like she brought out the other incident of the HIV or the AIDS times we had initially. But again, you saw again with it in COVID, where homes were shunned, and now again in Ebola, still individuals are the survivors are shunned because they believe that you still have Ebola. Remember, there was also a connotation on sexual intercourse. You remember? Now imagine how do the homes now survive? Meaning many homes, many homes broke, and many still would believe that if they say, did they say 6 months?
Between 6 months to 1 year.
Between 6 and 1 year.
Ebola
Now tell me.
Semen of a man.
So tell me.
For up to a year. Imagine that. Yes.
Would a family be there?
Not at all.
Or if it is a man that had Ebola. Or even suspected to be having Ebola.
So total breakup.
Total breakup. So, but what I loved very much, our communities are so resilient. And once information comes through, our communities respond. And I'm so happy that the leadership, district leadership, was engaged. And also the communities engaged. Like she mentioned, communities of people living with HIV, because they know where to trace individuals. They have that language. You know, like for example, if I access ARVs, you don't know in my community that I access ARVs, how will you bring ARVs to me? I might end up telling you, this is a wrong home. Next. Then you would stay with your medication. Again, that bit of psychosocial support, we really applaud UNAIDS for supporting SALT. SALT has a toll-free, line, and they were supporting individuals with psychosocial support. Yeah, like I mentioned, there are a lot of mental health breakdowns, psychological distress. And mental health is something that we are not speaking about. The overall well-being of a person. Here are people who lost their businesses. Here are people who have now lost families because you are not supposed to engage until that period of time. But do you think the people are not engaging until that period, until the time they've talked about, it's a bit of a challenge. And again, when it comes, it goes back again to our health systems. I would really like to appeal and very much. So governments, our health facilities need to be equipped.
That's right.
Our health facilities, it's as if we didn't learn much from COVID. You realized how people really suffered and were hit hard. So we really appeal to government and also development partners to surely support. And what I really love most is that when lockdown ended in those districts, our donors never said that we should stop because there are those after effects. Yeah.
Okay.
And she talked of economic, distress and where also people lost their small businesses, and now this is where again we are appealing to government. There are those government programs, PDM, EMIOGA. Actually, should let them try to focus also in those areas that were hit by Ebola, because people lost their small businesses and all that. And I also appeal to the communities, the PLHIV community in those districts. Please reach out to our colleagues. Please, there are those self-help groups. Yeah, let people join those groups. I think these are some of the things that should wake our minds up. Not to wait for a pandemic or epidemic to strike an area, and then after we begin thinking, okay, now I think now individuals can be helped in this and this way. I think we are going into that bit of planning in the direction of preparedness, and what if a pandemic strikes or an epidemic comes, what do we do? And I like it very much the way they've done it in other areas where we've had breakout of malaria, and you heard lately about cholera and malaria. I think there was a way that government rushed to contain the situation, and we had less of it, but people were hit. Yeah, the same way, because malaria kills people, and I think malaria has killed more people than Ebola did probably.
Yeah, sure.
And I think we shouldn't take it like an epidemic comes and we're like, wow, this is very dangerous. It causes panic. It causes that psychological. And by the time the person comes back into normal, and that is if they came back into their real senses, you realize now that people are completely, in some sort of different world.
Okay, interesting.
Yeah.
So this is where we're going to start from. When we return, we're going to be discussing preparedness. Like you said. Yes. You're going to give the response when immediately after break. But what are we supposed to do in terms of preparing ourselves? Are we just going to sit there and wait for the lockdowns to be slapped on us? And then, so that kind of preparedness is what we are going to discuss after the break. But Miss Resty is first going to give us the response of women in regards to when Ebola happened after the break. Yes, welcome back, and we're glad that we still have you watching us. And today issues at hand, we are discussing how communities responded to the outbreak of Ebola just recently that saw some of the central regions like Greater Mubende being cut off, or it was the most hit, if I could say. So in response to what communities did, or what happened, how the community members responded to this, we hosted a good panel here. Madam Resty and from AWAC, and Mr. Raymond here with me in studios. We are grateful to have you. And now, of course, straightforward, we are going to Miss Resty. Please tell us the response of women, particularly because these are the people you represent a lot.
Yes.
Yes. So
thank you. Thank you very much. So when we look at response, and especially by our communities, we did something that usually, it's a model used mainly in HIV programming called CLM, community-led monitoring. And we ensure that us, the people in those communities, do the reporting of what's happening, what service is given, how, so we more of became our brothers / sisters keepers, and ensure that our colleagues get support, but also we deliver information instantly on how it happens. A person in Kampala may take longer to know what is in Mubende, but with the development of what I earlier called the community actors for HIV+, which we shortened for CAHIV+, using the CLM model, we're into those communities understanding what can we do better. And until now, this it's now a built structure that is really on ground, that gives updates on what's happening, who are those that are still battling with those effects of Ebola, how are they coping. We actually have a database where they just type in and information comes onto that database. It's a tool that we used to make sure that we get that on-time information or data about what is really in those communities. So that's one of the responses. And the second response was about creating what we call community health and livelihoods enhancement groups, which we shorten for CHLEG. CHLEG, CHLEG. And CHLEG is also a community initiative that it's more like a VISLA, a VSLA, but the unique aspect about this is that it goes beyond economic aspects. It also engages the health aspects, where women get together, do some savings, some loanings, but also get education or sensitization on health issues. And speaking about how to build resilience, economic resilience, this is one of the aspects, because if they had something like that, for instance, we knew that there is a lockdown, but how could one thrive through a lockdown? For instance, if they had an entity they could tap into to get a loan, they could probably have that loan than risk their lives. I will tell you an example. We went to Mubende during that time when it was still a big issue, and some female sex workers were telling us, I don't have anything to do. I have children at home, but there is a lockdown. But in any case, I really have to be out there and ensure that I get money to feed my children. And the police beat me on the street when they find me. So what I'm doing, I just sit on my door like this, and when I see a man, I tell them I can do anything, even if you don't wear a condom, it's okay, you know. That's so that that desperation, you see, and that desperation put them into high risk. And of course, you wouldn't want to judge a person because you don't know what they are going through. By the time a woman says, "I will do this to ensure my kids are well," some social aspects are hard to immediately erase, especially those inequalities that are created by social structures and the systems and all that. So it's hard to, but how do we address that, the aspect that she shouldn't be that vulnerable, you know, to be that desperate? How do we address that? And we are thinking, if she had an economic source where she can say, borrow me this, I can return it after. She wouldn't have been that desperate. And after knowing that Ebola even can be infected through semen, you know, so her saying you can come even if you don't have a condom means she's going to be sick just because of that high need. But the response in creating these legs is in a way to build that resilience from the word go. If we have learned from the COVID aspects, from now the Ebola, how do we build these aspects and see that the communities are not that affected when it comes to such emergencies?
Interesting.
Yes.
So, and when you talk of desperation, this comes when someone is really has failed to get an option to do something. So, and that drives me to the readiness and preparedness. What should we do when such circumstances do happen? So, and of course, Mr. Raymond, you're going to first drive me in this for a few minutes, like 3. Yeah.
All right. Yeah, like I said, communities are very, very critical in addressing, you know, their issues. And to start with, strengthening community systems is very, very critical. And this is my appeal to the district leadership to really engage these health community structures because they are very important. Yeah, remember I said that in every district we have a PLHIV network, and this is a network that does the coordination role within their district. So strengthening that structure is very, very important. Yeah. Now, when we look at the mental health aspect, it is very important, and I would urge Ministry of Health to put this at the forefront. Mental health is very, 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 very critical, and we realize that in communities where these Ebola, you know, struck a lot, you realize that it left some individuals hopeless, some individuals psychologically affected, like we've stated. And another thing is engaging communities, and that is meaningful engagement of communities, building the capacity of community leaders to reach communities, to reach actually those are the people who are at the grassroots. Like right now I'm speaking that if I make a message, my coordinator in District X will get the message, cascade it down to the sub-county leader, cascade it further to the village leader. So you see that sort of structure or information flow structure. So capacity building is very, very important. And last but not least, and very, very important, the Ministry of Health building a robust health system. It is very, very, very critical not to wait for these pandemics or epidemics to occur, and we begin building the ramshackle temporary structures that right now are useless, or even taking people to stadiums the way you saw now, naturally. Okay, leaving that aside. Sure. So and my parting shots are basically to encourage individuals that please reach out whenever you have challenges. Please reach out. NAFOPHANU can be reached out to, and we are located in Mengo on Sentema Road. Reach out to us. Reach out if you are in those districts. Find out where your district PLHIV office is, or your coordinator in that particular district. You will be helped, and that is where also others may come in from.
Yes,
Thank you.
interesting. That is Mr. Raymond, one of our panelists today. And of course, as we conclude, the readiness. Should we just wait and then be guided by government to do this and this, or the communities can also be well equipped in some preparedness?
Yeah, actually speaking of government, I think before I go into the question, I want to appreciate government this time around. This was very. I think it was great. You know
how they responded.
Yes,
Okay.
this time round is, you know, that Ebola took less time than we expected, and that was because of efforts of different actors. We want to acknowledge the efforts of the Ministry of Health. They did great. It was it was commendable, and we want to appreciate the efforts of international agencies, World Health Organization, UNAIDS, the communities, us on the ground. I think we did commendable work to see that Ebola did not take as much time as anticipated. You know what happened in Sierra Leone?
Yeah.
You know, it was bad. But we see that we actually went through it, thrived, and made sure that we go through it together. And when you ask about preparedness,
yes.
I think we need continuous sensitization. Let's not think that Ebola is no more and we relax. We should have continuous sensitization on these issues, because when we relax, we definitely will see that if there is a risk, it will yield into that problem, and it will come to the worst situation. We should always have trainings. There are trainings for community members that would enhance their capacities into being there and support one another. We see that there was a big issue on mental health. And how do we, because, you know, like I mentioned earlier, mental health is not so much appreciated yet, that it's a challenge, and we should have many people trained. For instance, if you ask a child what you want to be, you'll never hear them say, I want to be a psychologist, I want to be a psychiatrist, you know. Because these are not things that come up easily for us. But we have, actually it's by World Health Organization, which has a training called Problem Management Plus and Self-Help Plus. These kind of trainings will enhance capacity of a layperson who has never studied anything about psychology to becoming community para-counselors, to becoming those lay people that can support one another, groups of people, to becoming actually something that will not be affected by mental challenges. And the other thing is, when we are programming, we should always have the language of intersectionality. Let's not think that all people are the same. People are different. People meet challenges because of their different identities, who they are, what they are, their economic status, what they do, and all that. All that makes it up to see how this person actually gets affected. And the other thing is, we need documentation. Right now I'm telling you about our CAHIV Plus team who are on ground to ensure that information gets to us early. And if there is someone who has symptoms, we will know and they will report. It means we need such people and to do the documentation to see that all that is covered. So in winding up, I think those are aspects that we need to put up front to see that everything goes on well. And yeah, thank you.
Thank you so much.
If we can send regards.
We had a lot of time here, but unfortunately time is already up. But please, just 30 seconds each person.
Yeah.
Yes, as we conclude. 30 seconds.
Great, thank you so much. So I take this opportunity to send regards to my great team at AWAC, Alliance of Women Advocating for Change. I love you all very much. I want to take this appreciation to UNAIDS and World Health Organization for the support. You see, communities have proved that we can actually do this. And I want to send my special regards to my partner, Moses Mukasa, for the love and, you know, taking care of the family and my children.
Mr. Raymond, please, 30 seconds.
Wow.
Yeah.
I would like to really thank our donor, UNAIDS, who has really enabled us, reach this TV station. I send regards to the family, NAFOPHANU. Greetings to you, and I love you so much. I send regards to the entire PLHIV fraternity, that I love you so much, and I encourage people to reach out to. Please don't be silent, speak out.
Interesting indeed, you have to reach out. That has been our discussion on how communities have responded to the Ebola outbreak when it happened. So it doesn't need that you should wait, as we have discussed. Prepare yourself, be ready for something, because you don't know what will really happen. Luke Majumba Lenaitwe, I've been sitting in for Caro Noaman. Good morning.